welcome to everyone. It's nice to see some familiar names and faces, and some new names and faces as well, or new names at least. What I will do is give a bit of background just about the sort of the session hygiene. So I've already spoken about the recording. And then only other things to say is that if people can please stay on mute, put any questions in the chat or on the Miro board. Depending upon how many people arrive over the next couple of minutes, we may be able to flex that and have conversations as active part of the session, but it does depend a little bit on numbers. So I guess without any further ado, what I will do is just start to begin the session by giving a little bit of an overview of the CLEAR program, where it's come from, and apologies, a couple of people will have heard this before, but I'll keep it suitably brief. And then what we'll do is just discuss the program in a bit of detail about how the program uses data, and then go on to actually use some of the data that's used in the program ourselves by doing a sort of a very mini CLEAR project, which will involve the use of a Miro board and some of the analytics that we use in the program. So if anyone has any questions or comments about using Miro boards, if not used them before, please obviously let us know. So I will begin to share my screen. Just to quickly double check, can everyone see the screen? For a nod, yes, there's a couple of nods there. Okay, good. So a bit of background about the CLEAR program. Whenever I talk a little bit about the CLEAR program, I always say why. I always give a bit of background as to why the anaesthetist would have an interest in workforce redesign, because it's not a common career path for many anaesthetists. And the reason for me personally is that my dad became quite unwell about 7 or 8 years ago now, and ended up passing away from a gastric cancer. And the journey from his diagnosis through to his death was the kind of journey that we would not want any of our patients or colleagues to have. He is, so I didn't say at the beginning, I should actually introduce myself, but my name is John and I am an anaesthetist, and I also lead the CLEAR program. So when I say that it's not the journey that we want any of my colleagues or patients to have, my dad unfortunately did not get the kind of care that we would want him to have. He had a diagnosis of gastric cancer. He ended up, excuse me, he ended up having a late diagnosis. We were able to get him in front of the right surgeon, but at that time in London, your 5-year survival varied between 15 and 50%, depending upon which surgeon you went to. He had a good operation and had actually quite a good recovery, but unfortunately he got an early recurrence, and unfortunately became palliative. And as he became palliative, we took him home, and he wanted to die at home. And it was fascinating how difficult it was in order to enable him to die at home. And what happened is we got a syringe driver, which is a painkilling device that gives painkilling injections, delivered to the house shortly after he came home. But we didn't have anyone to help us set it up for any medications. So my wife and I had to pop out to, had to get the out-of-hours GP to come, bring us a prescription, go to the out-of-hours pharmacy with the prescription in order to get the medications, come back home and then get on the phone to the hospice. And they were able to help us draw up the right drugs, or tell us what drugs to draw up, and then titrate those drugs up over the coming 10 days until he passed away. And 2 days after he died, the palliative care team came round and asked if there was anything they could do to help. And for me, that sort of, the fact that we had challenges in getting him diagnosed, challenges in front of getting him to the right surgeon, challenges in giving him a good death, and all of it because the system wasn't lined up around him in the way that he needed. So I could see myself becoming a grumpy colleague in the corner, and I didn't want to be that person. So I took some time away from clinical practice, always had a love of data, but 7, 8 years ago, I could barely do a count or count if in Excel. So I got involved in this workforce modeling program, learned a little bit about data, started to be able to use a VLOOKUP and a pivot table, and over time learned about how there was lots of data in the NHS, and that data could do so much good, but in order to use that data well, it needed to be supported by very good quality conversation. So after doing that program for about a year or so, I came back into clinical practice and have been part-time ever since. In my non-clinical time, I started to do a couple of different projects, using data in organizations to help colleagues redesign models of care and workforce so people like my dad would get a better deal. And after doing a couple of these projects in 2017, 18, I was very fortunate that some colleagues at HE saw the work that was being done and said, "Oh, John, this is really interesting stuff. Do you want to help create a training program to train other clinicians to work in a multidisciplinary manner with colleagues from HR, finance, workforce, business intelligence, etc., to redesign models of care and workforce in a way that is relevant for patients?" And so that's where the CLEAR program came from. So CLEAR is a work-based learning program that trains clinicians to use big data analysis to deliver a model of care and workforce redesign. And what our aim is as a program is to create a self-sustaining community of practice in the NHS that improves patient care experience and outcomes, and also creates portfolio of careers for staff and gives them the headspace to drive change, because we know that improves recruitment and retention. And so the aims of CLEAR are therefore to create that clinically led culture that works collaboratively in a multidisciplinary manner with many other disciplines. This isn't just about saying, "Oh yeah, clinicians are just doing the workforce redesign and using data in a new way." It's about working well with lots of other colleagues to do so. There's the program also drives the creation of new skills within colleagues, and those colleagues can use those skills through doing projects to drive new ways of working, to give clinically owned solutions using local data. The program itself is divided up into a series of projects. So we're doing work in primary care, mental health, urgent emergency care, critical care, and an ophthalmology project, which is just starting in the southeast. And the program is so each of those clinical areas that we're working in all have one or more projects going on within them, and each of the projects has a standard way of working. So the projects are divided into 4 phases. The first is clinical engagement. The second is data interrogation. The third is an innovation phase where you can redesign the model of care and workforce based off of the findings from the qualitative analysis and the clinical engagement and the quantitative analysis and the data interrogation. And then the recommendations are delivered, which is in essence a new model of care or workforce that's operationally relevant to that system. The way that this program is delivered when we train people is we have a 24-week program where participants join for 2.5 days a week as a team. So we create a clear team and an organizational system, and the team does 8 weeks of clinical engagement, followed by which involves roughly 20 to 30 hours of interviews and 4 to 5 focus groups as sort of the minimum. There's then 6 weeks of data analysis, where the findings from the clinical engagement are compared with the data. The findings from the data are then cohorted, so the colleagues who are doing this work, participants in the program, then use the data to cohort the patients into a new way of working or a new model of care, and then build a workforce model on top of those different patient cohorts. Once that new workforce model is created, that's then sort of costed up and modeled through some of the potential benefits, and this is then presented, set up so that it can be presented at an appropriate level, be that divisional, executive, ICS, CCG. It depends upon what the challenge or the problem is. For this work, what we do is we use a set of analytics, and the set of analytics is, and I'm just going to re-stress, the set of analytics requires de-identified patient level and staff level data. I say de-identified, technically it's pseudonymized, but de-identified. And this data is stored in a cloud-based architecture, where the data is uploaded from the relevant organization. There's a series of transformation scripts that are applied to reshape and reformat the data, clean it, map it. And once that's done, there's then a visualization layer over the top, which is applied, and that's a Tableau visualization layer. All of this is done strictly within the realms of an ISA or DPIA, and none of the data is ever shared outside of this environment to any other party for any other purpose. It's solely used for the CLEAR program or for developing the program. That sort of hopefully gives a bit of a background to what the CLEAR program is, and how data is used in a sort of theoretical perspective. But what theory is great, but what's actually I find quite helpful is actually trying to use the data in practice to enable to sort of give a flavor for how that data can support change within organizations and systems. So in order to do that on the call, I think we've got about 15 or nearly 20 people on the call now. In order to do that, what I'd like us to do is to try and go through an exercise of doing a mini CLEAR project, where what we can all on the call do is what we're going to do is set up a Miro board, and what on the call we can do is write down all of the challenges that we see within the current urgent and emergency care system. And then what we'll do is we'll pick the key themes live that we all come up together on the Miro board, and then use the analytics to answer those key themes to see what some of the changes are going to be. So we have in total about 20-25 minutes for this process. So what we'll do is we'll do 5 to 10 minutes on the Miro board, and then 5 to 10 minutes on the analytics. I'd love to be able to give people a play with the analytics, but IG for sort of bid sets. So what I'll do is I will control the analytics, but we'll be able to answer some of the key things with the analytics. And if anyone does have any questions at any point, please, we can pop them in the chat so we can go off on follow appropriate threads of conversation to use the analytics well. So without further ado, what we're going to do is pop this link into the chat, and I will click on it myself. And what would be great is if everyone could get onto the, oh, wow, people are here already, amazing. Okay, and I now need to share my screen so that everyone can see the Miro board. And then we'll so what would be great is if everyone could go and just answer the questions on the sticky notes. And the question is, what are the challenges that you perceive that staff, organizations and systems face when delivering or receiving urgent emergency care services? So if everyone could just write down some thoughts on the sticky dots. What we'll then do is I'll then share my screen to show some of the analytics, and we'll then use the analytics to see whether or not the perceptions of all of us here on the call with the Miro board are true and bear up in the reality of the data. And then I'll talk briefly about some of the solutions that we could implement from using the data to answer these questions. So we've got some interesting thoughts here. So we've got challenges around staff supply. Yes. For patients, there's long waits. I mean, couldn't agree more. Organizations, there's allocating funds in the right place, having the appropriate estates. And you know, it's something that we do struggle with, is having good quality estates. In one trust in London, there's challenges everywhere with estates not being quite what they need to be, lifts breaking down, all the rest of it. So these are issues. I think the difficulty accessing the right support, I think that's one that maybe would even merit a couple of other sticky notes to kind of go into a bit more detail. because you know, that can be both from a patient perspective. You know, is that for symptoms? Is that for certain types of staff groups? Is that certain types of problems? These things are all sort of helpful to know. I think from an organizational perspective as well, the managing COVID with BAU, that is a very, very significant challenge, and one that is not, it's a really difficult to manage one, especially when combined with the estate. So to give an example, we did a clear project about a year and a half ago, and it was just about to be implemented. And they had some estate to create a frailty unit, which was going to be about 20 beds. And then that project went completely on hold because that estate got turned into a hot COVID ward. So there was this work that needed to be done in order to relieve some of the pressures within ED. So patients did not have long waits, and there was sufficient capacity, but COVID put a kibosh on that. I think the comments about no clear vision about top priorities and poor data access, I think these are difficult. These are very clear. It's difficult. There is a lot of strategy in the NHS, but getting it articulated and understood in a way that's relevant at a frontline level or within organisations, I think is a challenge. I think the issue about poor data access is one that many people feel. I think someone's put older states as a challenge in the organisations. I think there's probably old IT infrastructure is something else that could be sort of stated as a key challenge, and that's a sort of poor data access issue that contributes to it as well. Politics with a big P. Yeah. And I think it's important to have these conversations and to call out some of the challenges. Politics is definitely one of them, and one of the challenges that we face in that we try and use the data for is to help people see past their politics and see past their views, but just look at the data in a way that's objective, calm, and considerate. And that does need us a cultural change that we that we sort of all need to embrace. But I think that's a very fair point, and one of the things that we drive in the program. Lack of community services outside of hospital, I think that's a really interesting point, and it's one that we can definitely look out in the data. Skilled staff, I think this is, again, these are all valid points. Actually getting the headspace for staff that are burnt out, but when you've got this huge pressure of elective demand, to then have the time and space to develop, I think that's really, really difficult, and it's not something that we create the headspace for, which is really there will hopefully be improvements for this over the coming months and years, but there's I don't think there's a reticence. I think it's just the operational pressures get in the way that allow people to have the appropriate time and space. I'm just looking at the chat to see if there's anything coming through that's not on the Miro boards. So we've got, let's see, where have we got here? So we've got no clear vision of top priorities, clear vision, lack of community services. Yes, that's very true. Competing priorities. The working in silos, it's really difficult. And I think data is stored in silos and people think in silos, and we're all sort of human at some point. We all want to work in a way that, we want to be part of a team, but the challenge that we need to put to ourselves is our team being one NHS with one goal to look after the patients, or do we put ourselves into organizational silos? And I think that's a question that we all have to ask ourselves. There's people, I've come across people over time that have said that it's not one NHS but the United States of the NHS, and I think that construct is potentially true, but something that we could in parts, but I think it's something that everyone kind of wants to break down, but it's something we all have to challenge ourselves to do and to keep trying to do well. There's a couple other comments about over-medicalisation and a lack of holistic care. These are things that we can take a look at in the data as well. I think they're really good points. There's some particular areas where I look, if I was being honest in my anaesthetic practice, I don't do much chronic pain at all, but there's a belief in the chronic pain pathways that actually, if you psychologically support and have appropriate wraparound care for patients, you can do a lot of good, and more so than injections in the back. So I think the over-medicalisation patients, that's just an example of anaesthesia, but and chronic pain, but there's going to be lots of other examples as well. We're doing pretty well here, and we have a range of different. Why don't find out why people fall? Just throw life belts. Yes, so I think that's a valid point as well about prevention and having investing more in prevention and more in support. I think that's a really useful point. Well, look, I think we've been about sort of 5-10 minutes here, and there's a number of very, very, very good points. What I'm going to, so please, everyone, feel free to keep using the mirror board and adding in more bits. But what I was going to do is take a theme here, and then what we can do is go and explore it in the data and see whether or not it's true. So what I'll do is just starting sort of at the left and looking at long waits, lack of long waits, high demand, lack of community services and capacity. What I want to do is go and look at the data and see if we can evidence-base that. So we have some data. Let's just imagine it's from sort of St. do about it. So I'll pop over and share my screen. I'll go into full screen here. And can everyone see this? I've seen a nod. Yeah, brilliant. Okay, fine. Just making sure. So what everyone's looking at here is something called a Sankey diagram. And a Sankey diagram is a great way for visualizing patient flow. And this is looking at 151,000 patients. And what you're seeing here is how patients flow into a trust that has 2 sites. And within this trust, within this flow, you'll see patients that come via walk-in and those via ambulance. And what you're seeing is how they go into the sites and all the different physical locations that the patients go to before either being admitted or discharged. And some patients are discharged sooner rather than later. So after 1 or 2 movements, some patient groups are discharged. Whereas some require multiple movements before having a decision made regarding admission. Now, what you're also seeing here is the patient pathways. So if I just let the sort of tooltip come up, what you can see here is that there were, of the 150,000 patients, 10% walked in. They came into the HRI, they then went into the ED walk-in waiting room, then into minors, then they were discharged. We've got another patient pathway here, which is something similar, again, into the waiting room, into minors, then discharged. What's interesting about these diagrams, and this is when you look at a lot of them, is you can see relatively early on which patient cohorts are the ones that you would want to address. And that's from looking at the fragmentation of patient pathways and the number of movements. So what you want to see is big fat patient pathways, because that's high levels of standardization, low levels of variability, and also few movements before being discharged. And so you've got that for some of these patient pathways here. What you'll a little bit sort of want, what draws your eye is the fragmented patient pathways with lots of different movements through the system before having a decision made, be that admission or discharge. And what you're seeing here is that you've got, actually overall, when you look at some visualizations from some organizations, this is a pretty good one, because there is some fragmentation from the ambulance arrivals, but there's also quite a few high volume patient pathways that are standardized too. Now, so we know that there may be some issues to uncover here, but if we go back to what was said in the comments looking at patients, the things that we're sort of worried about were long waiting times and lack of community care, and whether or not that impacted on patient experience. The other thing that was mentioned was around over-medicalisation of patients. So in this particular analysis, I think what is helpful is it's worth looking at the patients that there's probably worth looking at a patient cohort here that's liable to have these kinds of issues. And the patient cohort, this is far more likely, those particular issues that were pointed out on the mirror board are far more likely to generally happen in the elderly. So what we can do in this analysis is we can sort of say, okay, fine, we've got this issue that we want to look at, over-medicalisation, long waiting times. Let's just have a look at elderly patients, because we know, that in most, the highest demand for healthcare services, especially for urgent intervention care, tends to come from elderly patients. And we know that they don't tend to get, that's where some of the issues can arise. And what you see here is we've gone from looking at 150,000 patients to just 27,000. We're also looking at roughly 60 to 70 attendances over the course of the day across both sites. And we're looking at a sort of average waiting time of about 3 hours and 50 minutes. Now, there was a point made in one of the other post-it notes that data doesn't spreadsheets tell you how staff works. And I think that's a really important point, is that someone else mentioned about poor data quality. And in this data, there is some variance. If you go into the back of it, there is some variance between the two sites in terms of how things are recorded. So what I'm going to do is just let us look at one site so that we can analyze it in sufficient granularity, so we can understand, so that any solutions we come up with can be applied appropriately. And what you can see here is that actually the elderly patient cohort that we'll decide to look at has dropped now down to 15,000 from 27, and actually the long waits have gone up even more. So there's a couple of things here that we can tease out from the data already. We know we've got some concerns about these patients in urgent emergency care, and we also know that it's borne out in the data that we should be concerned about these patients. There is evidence here to suggest that they do have longer waiting times, but it's great to say that that's some evidence, but we want to understand why this occurs and what we can do about it. So if we go back to look at the patient flow again, what we can do from this analysis, so remember we've gone from looking at 150,000 patients down to 15,000. And in this view, what we can see is all the different staff groups, all the different patient pathways. And as you can see here, there's now much higher fragmentation of the patient pathways. Patients are admitted after much more frequently admitted, and there's a much greater proportion of the patients that have multiple movements. So if we then go on to look at the waiting times and see whether or not that's borne out. Let me just click on. The best way to kind of do that is to look at some heat maps, and the way that we can look at the waiting times for patients to be seen is we can see, well, there's a couple of things that we can do. first thing we should do is look at volumes. And the point that a colleague made on the mirror boards is that lack of community services. If you look here at this heat map, you can see that actually on the weekend you're getting pop the attendance flag on. What you can see is you're getting 200 attendances at 11 on a Sunday, and in the week you're getting 150. That's a 25% reduction, and this is almost certainly due to the availability of services and staff in community and primary care. So if you look at the pressures that this particular Goodwill Hospital is undergoing, and the concerns that have been raised by everyone on the chat, these are borne out in the data. You know, there's clearly something here that we need to do something about. There's another point that was made in the data about in the mirror board about long waiting times, and we can absolutely look at that in this data. So what you're seeing here is the change is the time of waiting from when a patient attends to when they see a doctor. And what you're seeing here is that actually this particular amount of time is goes up to 2 hours, 2 hours and 20 minutes before you see a doctor, or even before you see a nurse in sort of the late hours, early morning. And what this is telling us again is that these patients do have long waiting times. There's a lack of community care. So all of the concerns that everyone has borne out in the mirror boards are present in the data. There's then another point that's made, which is around the care and diagnoses that people receive. So another point that a colleague mentioned was about over-medicalisation. If we look at this patient cohort, what we can do is we can take a look at the analysis and see if and how these patients are over-medicalised. And if we look at this data, you can see here is that a lot of these patients turn up with falls, head injuries, UTIs, some people who are more sick with sepsis and pneumonias, and more severe stuff like a fractured neck or femur. But the vast majority of these, there's a significant proportion of these attendances, probably around 2,000 to 3,000, where you think that their care could be better managed elsewhere. The other point to mention with this patient cohort is that they have lots and lots of investigations done, but not that many treatments. And so this then alludes to the challenges that the challenges that exist, and that actually these people probably aren't in the right place, and therefore the things that are done to them aren't necessarily the right things that need to be done to them. So the question is what you can do about it. I guess actually at this moment, I would just like to stop sharing, because what we've done is we've looked at some comments from people's thoughts. We've looked at the data, and what everyone said is true. It's borne out in the data. What we then normally do in a clear project is then try and come up with some innovations or ask more questions of the data at this point. So what I'd like to do is actually stop sharing my screen, and we have quite a few people. We have enough probably people on the call, and to see, does anyone have any thoughts about what can be done here, both in terms of new models of care and workforce, to answer the questions that have been posed and have been answered by the data? And please feel free to sort of raise hands or to write some answers in the chat. But I'm just keen to get a bit of conversation and thoughts about what could be done to solve this situation, given the data. And if more data is needed or more analysis is needed, obviously we can mention that as well, and we can go back to look at the data in more detail. But does anyone have any thoughts about what could be done in this situation?
Martin has popped some thoughts in the chat, John. I don't know if you've seen.
Excellent. So Martin said, weekend can be down to the system as a whole, just doesn't work weekend, not just community care. Care home staffing levels impact time and day of admittance. Yes, that is very true. And actually, if we were to look at the data, which we could do, also ambulance shifts make a difference as well. You get a spike after a reduction in attendances just before the ambulance handover and just after as well. But Martin, you were going to say something. I apologize, so you come off of mute.
No, it's great to see you again, John. No, I mean, it was, it's that thing, isn't it, that all the data I think you've got to be very careful with the data, that the data just doesn't prove what you think, or you try to use it just to justify it. And I think sometimes I suppose it is that thing about damn lies and statistics, really, in the fact that any good sort of person can manipulate the data to justify what they want to happen. And I think there is that thing about how can we encourage debate, and what you know what I say about it, which is it's those adult conversations that you need to have, and that safe sort of space about saying, well, let's explore this, let's just try to really understand it, and try to move on. And again, my take on it is that, my experience is that sometimes if you end up with the wrong level of person seeing the patient in ED, then they will be admitted, because the level of risk tolerance which they have says, I'm not prepared to take the risk, I'm going to admit the patient and let somebody else do it. And then we know what happens is an over-keen, junior doctor with an underworked, med reg, or an overworked med reg, they admit them, ask for loads and loads of tests, then they end up staying in hospital waiting for the results to come through. And whilst they're in hospital, they lose mobility, they become more frail, they then become more difficult to get back out. If we're really unlucky, they end up with a hospital-acquired infection and die. So the amount of people that sometimes people don't like to say it, but actually we can actually kill people by actually admitting them to hospital if we're not careful. And that's the system that does that. And I think we should be, quite open to that sometimes just because we can shouldn't mean that we should. And it goes back probably to that more fundamental thing about that sort of initiative now, which is talking about what's really important to the patient, not what we think we need to give the patient. So I think, I think we just got to be careful with it. But I think the data is really, really important. And I think it's just getting people to be, not to get over worried about the data, but just to see where the themes are going and what it's really telling you. It doesn't have to be accurate for it to be useful.
I completely agree, Martin. That's a very valid point. And I suppose on that note, you mentioned about where we place the senior decision maker in the patient pathway, and one of the things we could explore in the data, should we choose to, but conscious that other people have made some comments that we need to address, is what the flow looks like when you have a consultant on the shop floor between the hours, and what the flow looks like when you don't have the consultant on the shop floor. And what you see is increased fragmentation of the flow when the consultant is not there, especially if they're not early on in the decision-making pathway and triaging. And the other thing that I think is, so if you go back to those Sankey diagrams, you can basically filter to look at what happens in hours 9 to 5 and what's the flow. And through qualitative engagement with staff, you can say, oh, well, the consultant is on the shop floor at those times. So you can see a visible difference in the flow and the impact that it has on patients. Simon, you made a very sort of good point about improved diagnostics and staggered shift changes. I think we can again go back. One of the things that has happened from using some of this data is that the workforce model has been changed to access diagnostics, and that's literally something as simple as you don't need a nurse to take a patient from the A&E department to a CT scanner. You can just get a porter to take them if they meet a certain level of criteria. So if you've got 2,000 CT scans over the course, you're taking a nurse off the shop floor when you've got a very busy time out of hours, when you can just use a healthcare assistant to do that for the right patient if they're not too sick. And so if, again, we could go back and look at the data, but if you look at the demand for CT scans, if you look at the demand for CT scans, then it happens out of hours. Actually, you need to increase your non-registered and unregistered staffing to help look after this particular patient cohort and improve their access to diagnostics. And the staggered shift. I don't know if you want to build on that at all, Simon, because I think it's a valid point. Location of diet. Yes, yeah. Not having it down the hall on the other building, there was one trust that I worked at where if you wanted a CT scan from ICU, you had to actually take the patient out of intensive care with a ventilator across the road and then up to a CT scanner across the building. So yes, the location does make a difference. Natalie, better pathways to manage people with long-term conditions. So interestingly, in this particular situation from the data, it was quite evident that if you looked at those patients, there was a new workforce that was needed for about 3,000 of those patients. And the pathway was in essence a frailty unit. There was a 24/7 unit. So what the data did is evidence that actually with that cohort of patients, you could build a whole new service and get that service staffed with OTs, physios, nurses in a much lighter medical model. So going back to the point that a colleague made about lack of medical over-medicalisation, this data, or that data you just looked at, actually formed the basis for a case for opening up a whole unit and then changing the establishment of the workforce. This is a very valid point. Louise, that's a really interesting point about having consultants on the shop floor and CDU reductions reversed in 6 months. I don't know if you want to share anything about that, Louise, because it's actually quite a nice story.
Yes, I will. Thank you. I was emergency care pathway redesign lead at Birmingham Children's Hospital quite a few years ago now, and was working with the medical director and one of the lead consultant paediatricians, and the lead paediatrician was very, very into, let's have some data to prove what the issues are, and then we can look at how we can improve it. And whereas Birmingham Children's was meeting the 4-hour target for the ED patients, generally, what they weren't doing was those GP referral patients were coming into the department, and because they weren't on the 4-hour clock, they were sat to one side waiting for relative specialisms to come down and see them. So we opened the CDU from 2 p.m. till 10 p.m. Monday to Friday, and only staffed it with consultants. So there was a consultant of the week who was on Monday to Friday. They weren't allowed to go anywhere else. If I walked down there and they weren't there, I had to go around the hospital and find them. And they saw every patient who came through the door, and they used it as teaching exercises with the AMPs, the junior doctors, but also the number of admissions greatly reduced. We also at the same time introduced a Me at BCH passport for the children with long-term conditions, because you could guarantee on a Friday night before a bank holiday, they'd arrive in ED and you couldn't find the notes. We put an alert on SEMA that they had an electronic document within their SEMA system, and the patients and their carers also had a paper copy. And in there, it would say things like, my saturations are 90%. It doesn't matter how much oxygen, what you give me, they won't go above 90%. So basically, it led to, on one occasion, the clinical director thinking, well, that's normal for that child. I'm not going to do anything else other than various other things. And that child didn't get admitted that weekend, whereas normally they would have done. And then they'd disappear into what I used to call the black hole of BCH, come out a month later. And the part about only ordering tests if it was actually going to change the management, that came from the clinical director for pathology and I've forgotten the word, hematology, that's right. And rather than have all the juniors order a raft of tests because there wasn't a consultant on the shop floor, if it wasn't going to change the management, the CD for hematology would actually ring down and say, why do you want these tests doing? What are you going to do that's any different? And if they did want something, we had lots of SOPs in, standard operating procedures in place, then that was fine. They could follow that if that's what was necessary. And it didn't actually matter who looked after the patient, whichever bit of their journey within the department, they followed the SOP so that they weren't constantly handing patients off. And in the first 6 months, we saw a huge reduction in our admissions. And even if ultimately they were admitted into PAU, then the following day, the first question to be asked would be, what are we doing for this child that cannot be done at home? And if that meant altering the drugs from IV to oral or changing the number of times the IVs were given by the community nurses, we would do that to help them be discharged. The best thing we could have done with though was Nick Knowles to go out and refashion all the houses so that they didn't have to wait in hospital for house alterations. But it really did work. So it was really useful work.
No, it's fantastic. And I think the points you're making are actually very valid, what I would call workforce sort of productivity issues.
Yeah.
Because in essence, what you're doing is you're getting the right staff in the right place so that they can be as effective as they can, and actually not doing something is actually sometimes quite productive.
And we knew that the majority of children who were the GP referrals would eventually get to the department by about 2 p.m, 1:30, 2 p.m, because they'd been poorly in the morning, mum or carer, dad, whoever, had taken to the GP by the time they'd got their GP appointment, and then come to the hospital. So you didn't need to staff the CDU first thing in the morning.
No, it's brilliant. It's brilliant. It's brilliant stuff.
Really, really good. We presented it nationally at the time, but we are going back to about 2013, I think it was.
No, and I think that, but this is the kind of thing, it's creating this community of practice so that people can do this kind of work in a standardized manner, accessing data effectively and using it, having appropriate, constructive and challenging conversation, no matter where you are in the country. And so creating that framework, and empowering people for the how, that for me is, and I mean, it doesn't need to be a clear program, that's what the program's about, but any motivated group of individuals can do this kind of work. The key is having the structure, I call it tools, training, and time. It's about having the appropriate training to do this kind of work. There's time freed up in the headspace to do it.
Yes, which we were lucky. We did have. We were very lucky to be able to have the time to do that, and I had an excellent team of people working with me, all motivated to do the same thing.
Yeah, fantastic. Brilliant. It's a great story, Louise. Thank you.
Thank you.
I'm just conscious of time because I think we were meant to finish about sort of a couple of minutes ago, and I'm conscious that it's everyone will be busy getting off with things to do in the evening. I apologise that we've not been able to go through all of the very, very good points that were placed on the mirror board and evidence-based them with the data. As you can tell, with this data, you can go into lots and lots and lots of detail around what some of the issues are, and then what some of the solutions are, be they a change in the model of care, change in the model of workforce, or ways of working to improve productivity. All of those things can be evidenced with the data, and by having good quality conversations, as both Louise and Simon, Simon, I know Simon would allude to, but Martin and Louise have alluded to as well. Before I guess we sign off for the session, does anyone have any questions about anything that's been presented, or any thoughts before we get on with the rest of our Wednesday afternoons? It's evening, it's night, isn't it now? I feel, but yeah. Simon.
Yes, so I was just making sure I was coming off mute. John, you and I know each other quite well now. What I'd like to say, what Clear gives for me in a transformation team, is that placement of people who are absolutely key to transformation, improving the systems. Some help and some education about how to use data effectively and everything else. The problem I have within a transformation team, and what we're trying to do is to get the right people around the table, and we don't always get those senior clinicians there. So we can agree to do an awful lot of work using the 6-step process and the HE-STAR, but when it actually comes to getting buy-in with the movers and shakers, those senior clinicians, consultants, and all the rest of it, to ensure that we can carry their work forward, we quite often come up against a bit of a we lose momentum. we don't get over the start line. So where I see Clear working really well with HEE, and probably why Kirsty Bax has been very keen to use it, is it places those people almost like sleepers in that organization waiting, and then we come over the hill. I've often used the term like the cavalry coming over the hill, but in some respects the cavalry's already there, but it then dovetails nicely into what we're trying to do. So when those programs of work and those improvement streams are identified, we already have the right people who get it, and I mean get it, and transformation in the system with an oversight and understanding of how to use data effectively, and then we can really start working together, get things moving. Thanks.
Wholeheartedly agree, Simon. Yeah, thank you. It's a very valid point. And by building that momentum, by building that community of practice, that's what's going to enable us to do the right things that our patients are going to need from us over the coming months and years. And the pandemic, if nothing was crystallized before, that hopefully the pandemic has about the need to make these kinds of changes. Fantastic. Martin.
Yeah, I suppose my sort of take on it is that we shouldn't be scared to actually ask the difficult questions with the data and really be prepared to ask the boundaries. There is a real danger that just because you can measure something, it gets measured, and then it's, oh, I'm going to change that. So I think the diagnostic argument is a really good one, that actually the questions we should be asking about diagnostics is how many diagnostics have we requested, which made absolutely no difference to the decision that we've made and to the clinical care that we've provided. Because the problem is, I think sometimes, and again, I'm going to be very critical maybe of some junior doctors, and it might be just because they haven't got the right support there, but the safest thing for them to do is to ask for loads of diagnostics just to make them feel better about a decision they're making, when actually if you got the consultant in the room, he would have turned around and said, or she would have said, one, you don't need a diagnostic, and actually get on and do something differently. But I think sometimes it's really difficult to give people that safe space to have those discussions. So I think it is about getting the right clinicians in the room and empowering those clinicians to be able to make a change. Because I know a lot of senior consultants who just get basically pissed off with the politics of the NHS, and they give up trying to make any changes, even though they know what's right for their patients. And even though we present data to them, which actually proves what they want to do, but because we're more interested in chasing figures and getting a tick in the box, oh, we've reduced our diagnostic weight down because we've added another MRI scanner. Actually, how many MRIs did we really need? But I think that's just the dynamics of it all. But I think if you're going to really make a change, you really need to be brave about really challenging the conventional models of how to deliver proper care that adds quality and actually sorts out this process, because you're never going to have enough diagnostics. You're never going to have enough doctors unless we fundamentally change our approach to the way which we deal with care.
Fraser 2021. Yeah, you're sorry, I was just talking on mute there. I think it goes back to Simon's point very well, which is that you've got to be able to have the right conversations and get that clinical engagement early on in a holistic manner, not driven around the data. And I think that is something that as people and as a program, I think is just absolutely vital. And the more that we can do that and have those conversations well, the better the chance that we have of really making tangible changes for patients that are long lasting, sustainable. It's not just a flash in the pan, which I think is just fundamental and key. Brilliant. Well, if there's any, if everyone is happy with where we've got to, which is a very positive note, I think, for an end of a Wednesday, please, any more questions? But if there's no more hands flashing up or comments in the chat, what I'll do is just thank everyone for your time this evening, and hope everyone has enjoyed the session. And if there's any thoughts or comments, just please get in touch. We're happy to share, and I always happy to talk data and transformation. So have a great day, everyone, and yeah, look forward to seeing people in the not too distant future, I hope.
Thanks, Sean. Cheers.